Right, and it's about time for the witching hour here. 12:10 is upon us, so we'll go ahead and get started. Thank you for all attending this week's edition of Grand Rounds. If you haven't done so, please make sure to sign in and grab an evaluation sheet. Today we're very fortunate to have Dr. Michael Savona from the Sarah Cannon Research Institute in Nashville, Tennessee, come to talk to us about myelofibrosis. Myelofibrosis is a process associated with hematologic malignancy of the marrow, and there's been a lot of research in the recent decade looking at different molecular mechanisms of myelofibrosis, and Dr. Savona has led some of that research. By way of background, he's been all over the country. He was a demon deacon for a few years at Wake Forest University for his medical degree. He ended up going to California for his internal medicine training, and then came back to the Midwest and was a Wolverine, University of Michigan, for his Hem-Onc fellowship training, and now he's in the beautiful city of Nashville, Tennessee, and we're very happy to have him, and so please join me in welcoming Dr. Michael Savona.
Can you hear me now? Thank you, Jamie. So I'm from Nashville, so this is known as the Taylor Swift microphone. That's about the only comparison I'll make to Taylor Swift and myself. I really am. Is that too loud? How's that? I really am a fortunate guest. This is I travel around the world and country giving talks on myeloid malignancies, and I've been to every state except North Dakota, South Dakota, Alaska, and Iowa. So thank you for letting me break the seal here, and it's nice to finally make it to Iowa. I think we have a mixed group of folks. It looks like we have some physicians, some ancillary care, some nurses at all different areas of the hospital. What I do is fairly narrow and deep, but what I'll try to do is try to make the talk relevant to your practice the best that I can. So the reason that myelofibrosis is more exciting to talk about these days is because we actually have therapy for it. So for many years, the treatment was largely palliation, and now we can do better. So I'd like to spend the next 40 minutes or so describing some of the advances, first outlining the disease, then describing some of the advances, and I'll talk about, I feel like I'm getting feedback here. How's that? Okay? Thumbs up in the back row, is that all right? All right. About some of the approvals that have occurred and advances and some things available to us, and then what's available down the pike, and then I'll end with, of course, time for questions. So, as a review, myeloproliferative neoplasms, and they used to be called myeloproliferative diseases, but then someone got the great idea to call this clonal expansion of immortal cells, what it really is, neoplasia. And now I have to tell all these PV patients who've had PV for 20 years that they have cancer. Or I have to deal with them after someone else told them they had cancer. But these are, for the most part, relatively indolent neoplasms. And many of these patients have survival equivalent to their age-matched controls. We want to concentrate on those who would die of their disease sooner than their age-matched controls. And when you think about MPNs, I would think about, I just got my voice back, so forgive me. I've had laryngitis for 3 days, to the great joy of my staff. Myelofibrosis neoplasms I like to talk about as pH positive or pH negative. The Philadelphia chromosome defines CML, or chronic granulocytic leukemia, or chronic myelogenous leukemia. And there's therapy that directly inhibits the Philadelphia chromosome's product, the BCR-ABL protein, and that stops the disease in its track. There are no dominant mutations that are known in these other diseases that can be targeted in such a fashion. I will talk about some relevant mutations, though. On the pH negative side, this is kind of my main area. There's myelofibrosis, primary myelofibrosis. There's also post-polycythemia vera and post-ET myelofibrosis. Thank you so much. There's primary polycythemia vera, which is an unregulated proliferation of usually the erythroid line, but can also include leukocytosis and thrombocytosis, which makes it sometimes difficult to differentiate between P. vera and ET. And anyone who's a vascular, deals with vascular pathology in this room, that's probably most of you, internists, cardiologists, surgeons. It's important to know if you have a patient who's a polycythemia vera patient or an ET patient, because that can complicate your surgical mortality or morbidity. And then, of course, ET is a clonal proliferation of the megakaryocytic lineage, high platelets, where patients can present with thrombosis, and then if their platelets get high enough, they actually bleed because they sequester all the von Willebrand's factor. If you can remember von Willebrand factor as the seaweed that kind of dangles on the inside of the blood vessels, and once all that seaweed is taken up, the platelets have nothing to anchor to when there's a breakup of the endothelium. On the other, I should just mention, some people go their whole careers and don't see systemic mastocytosis or chronic eosinophilic leukemia. I have a clinic of a few of these patients here and there. They're very uncommon diseases, and for the most part, like MF or P. vera, are not driven by one clonal aberration. The exceptions to that would be something like a FIP1L1 PDGFR rearranged CEL. And that's a translocation between two chromosomes that leads to constitutive activation of the platelet-derived growth factor receptor, and that actually can be inhibited by imatinib. So anytime you got somebody who's got really high eosinophils that you think has CEL, it's always important to look for that translocation. NPNs are clonal, and patients have a crescendo of constitutional symptoms and enlarged spleen symptoms. And I like the way this slide separates those sets of symptoms, but really they kind of overlap. As the marrow becomes more fibrotic, the stem cells go to they remember. There's embryonic hematopoiesis occurs in the spleen. So those cells go back to that old place of hematopoiesis where it's no longer possible in the marrow to the spleen, and that's where extramedullary hematopoiesis occurs. The body still needs to make blood cells, even though there's fibrosis occurring in the bone marrow. You still need to make red cells and platelets and white cells. And as the spleen grows more productive in that, it grows larger. And as it grows larger, it uses more and more nutrition and pushes on the stomach, and less nutrition can come in. So you can see how this is a cyclical process where people get bigger and bigger and bigger abdomens, and I'll show you pictures in a moment, and more and more cachectic. Along with the growth in the spleen, this is an inflammatory process where people develop feverish chills, night sweats. They develop some weird symptoms like acroparesthesias as they have microclots in their distal microvasculature. They can develop erythromelalgia for some of the same reasons. And sometimes just the worst pruritus you've ever seen. Just to give you an idea, this is a nice little study that was presented at our annual conference, ASH, a few years ago, done by the Mayo people. And you can see that pretty much everybody has decreased quality of life and fatigued. But then it's a smattering of other symptoms. Some people you'll see they have classic big spleen, cachexia, early satiety, night sweats, leukocytosis. Some people are referred to me with no spleen, just no hepatosplenomegaly anyway, fibrosis, leukocytosis, and some weird itching or acroparesthesias. They're not diabetic, but they can't feel their toes. The survival in primary, and this, we use PMF, and historically PMF is primary myelofibrosis, but really that's a very difficult thing to distinguish from post-ET and post-PV-MF, or PET-MF and PPV-MF. And it's kind of a funny historical thing. I mean, we call myelofibrosis PMF because we don't want to confuse people with mycosis fungoides, which is a lymphoid malignancy primarily of the skin. But you can see the median survival of this disease is actually, it's a fairly indolent disease, and 50% of people are alive in 6 years. That includes all comers. So it's really hard sometimes to tell the difference between the 80-year-old who is going to live 6 years with the disease and the 80-year-old who might live 3 months with their disease. The first attempt to try to stratify patients was the International Prognostic Scoring System, published about 4 years ago by the Spanish, where 5 risk factors that are listed here were reviewed and looked at, and by stratifying with these risk factors, you could actually separate curves. You could actually separate groups of patients into low risk, intermediate 1, intermediate 2, and high risk. And the median survivals are vastly different, ranging between 2 and 13 years. This has been refined multiple times, and I use something called the DIPS Plus scale. And DIPS is like the IPSS, only it allows us, it's been validated not just for upfront diagnostic analysis, but as the patients progress, which is really helpful because, as you may or may not know, the IPSS for MDS is only validated for diagnosis, but you have these patients for years. And it's important when they progress that you can get an idea of how they're going to continue to do. And that's what the DIPS Plus allows us to do. DIPS Plus adds in some other poor risk features that weren't accounted for when the first IPSS scale came out that include carrier type, platelet transfusion need, and low platelets. So, and I should say that using DIPS Plus, there's even higher risk groups where the median survival has dropped further. This has been very helpful for us to decide who goes for definitive therapy with allogeneic stem cell transplant. Do you do allogeneic stem cell transplants in Ames? No. Are they done in Iowa, Des Moines, or at Cedar Rapids, or at University of Iowa?
Iowa, Mayo, and Omaha.
Okay. So, yeah, so I know big transplant programs for myelofibrosis in Mayo and Omaha for sure. For years, this was the only therapy, really the only definitive therapy, disease-modifying therapy available. And I'll talk about some of the attempts to define disease-modifying therapy in a moment. So myelofibrosis often has a lead time for many years and largely goes undiagnosed. Sometimes people have vascular events. I can't tell you how many patients are referred to me with a family history of early vascular disease, but their mother had a Budd-Chiari, their grandmother had a upper extremity clot, their sister had a DVT, and their hypercoagulability workup was negative, a lot of CVAs, and it turns out that the marrow was finally done on this person, and the marrow revealed fibrosis and clonal proliferation consistent with the disease of primary myelofibrosis. When people develop or are diagnosed with overt MF or post-ET MF and develop these symptoms I talked about earlier, this usually goes on 2, 3, 4, 5 years. And then patients either their disease progresses, and I'll show you what happens to these patients, and they just get weaker and weaker and weaker and develop further complications consistent with their disease progression, or they spin off into a leukemic transformation. And it turns out that about a third of the patients, at least, and this is retrospective analysis, but this is a very strong retrospective analysis where 1,000 patients were looked at and 500 deaths were analyzed, and a third of the patients developed acute leukemia from myelofibrosis. So actuarially speaking, we know that people have about a 30% risk of developing acute leukemia if they have post-ET, post-PV, or primary MF. Obviously, the other parts of this pie here, overlap. There's a lot of patients with pulmonary hypertension who die of vascular complications. There's lots of patients with bleeding complications secondary to portal hypertension and so forth. So I mentioned allogeneic stem cell transplant. You know, I'm at a kind of a boutique transplant center. We do about 100 transplants a year. I mostly do drug development at Sarah Cannon in Nashville, where we have a very large phase 1 presence. We do allogeneic stem cell transplants, and we reserve allogeneic stem cell transplant for the fittest of the fittest myelofibrosis. Big centers like the Mayo and Fred Hutch have investigators who concentrate on transplanting myelofibrosis tend to be a little bit more aggressive and take people who are sicker. But this is the adage with myelofibrosis is either you're too sick to transplant or you're not sick enough. And it's a very hard thing to figure when you're taking care of these people. So when you see survival data like this for patients with allogeneic stem cell transplant and myelofibrosis, you have to keep in mind that 50% are alive in 5 years, but those are people who weren't really as sick in the first place. Because if you're too sick, you're not going to go to stem cell transplant, which is a kind of a chicken egg thing. We use the DIPS plus scoring system and say intermediate 2 and high risk patients are good patients for transplant, and those less should be handled on a case by case basis. But if you're INT 2, you usually have symptoms and a decreasing or declining performance status. In addition, if you're needing transfusions, we know that hemosiderosis from multiple transfusions is an independent risk factor for death associated with allogeneic stem cell transplant. So that's just a kind of a kernel to think about as you care for these people and you think, who should I transfer down the road to be considered for allogeneic stem cell transplant? Sometimes it's easy. You have someone in their 30s and they already have myelofibrosis, and it's just a matter of when you send them. Sometimes they're 80 and they're never going to be a candidate for allogeneic stem cell transplant. The hard ones are the ones who are 65 or 62, and they're going to age out of stem cell transplant, and they feel good, but you don't want them to age out when they feel bad and not have that opportunity. Hate that slide, sorry. So this gets back to the point I was making a moment ago. Andreas Bacigalup from Italy looked at, with a thiotepa-based reduced intensity transplant conditioning, and a mean age of 51 years. So these are younger patients. Patients did well if they were lower risk, which gets back to this chicken and egg. If they're low risk, then those are the patients maybe they didn't need to go to transplant. But if they had higher risk and they really need a transplant, they don't do as well. And that's because, like I said, they already have that iron deposition from their transfusions and big spleen, which makes them more cachectic and poor, low albumin, poor nutrition, et cetera. What about non-stem cell therapy? Well, there's lots of different therapies that have been used to control different parts of this disease process. This slide needs to be updated. But prednisone, I still use androgens on occasion. I use EPO on occasion. And the IMiDs, which include thalidomide, then the next generation lenalidomide, and then the next generation from that, which is now pomalidomide. Pomalidomide is tricky because it's a fortune, and it's approved for myeloma, and it's hard to get for your patients with myelofibrosis, but on trial it can be gained. And there was just a large trial that was completed, and it looked like there was no benefit on patients with myelofibrosis receiving pomalidomide, but if in the subgroup analysis there are benefits, and it's typically patients who have anemia-centric disease. Because like I told you, there's a hodgepodge of symptoms people get, and some people are more anemic, some people have more nutritional, big spleen issues, some people have more fibrosis, etc. There's always some surgeons, when I give a general medical audience talk, grand rounds, and who ask about splenectomy. There's very rarely do I send someone to splenectomy anymore, not because I'm a non-surgeon, I don't like surgical procedures, but because it's a morbid procedure, and these patients, when they have their spleen out, they just go and develop extramedullary hematopoiesis somewhere else, and unfortunately that usually means the liver. And the last time I checked, we can't take the liver out. I don't think you can anyway. All right, so hydroxyurea has been the mainstay, and there is definite evidence that hydroxyurea the cytotoxicity of hydroxyurea can bring down splenomegaly. So if you just think about it as kind of a general mowing down of cell growth, there's less proliferation. I mean, that makes sense. Hydroxyurea is problematic because that reduction in splenomegaly doesn't work, because as one cell line goes up, sooner or later as the disease progresses, other lines will go down, and the hydroxyurea will complicate that. And probably most important, if you're taking care of young patients, is that hydroxyurea is teratogenic. And Jerry Spivak from Hopkins published, I think in the 80s or 90s, a longitudinal study of patients who had and cytogenetic abnormalities who received hydroxyurea. And there's two lines. There's PV patients who got hydroxyurea, and there's PV patients who did not. And I guess it looked like this. And the patients who had hydroxyurea had mounting cytogenetic abnormalities and disease evolution, genetic evolution. So that's just a word of the wise about, about hydroxyurea. So again, a slide that needs to be updated. Now that we're in October, I can't have slides that say in 2012 anymore. But who's heard of the JAK2 V617F mutation? Yeah, so let me just take a moment on that. Dr. Van Checker discovered, and then shortly thereafter, several labs published in all the top medical journals, New England Journal of Medicine, Cell, Nature, and Science, a long-sought driving molecular abnormality in myelofibrosis. And that is a point mutation in the intracellular domain of JAK2 called the JAK2 V617F mutation. That phenylalanine valine rearrangement changes the conformation of the protein so that the protein is on all the time. And JAK2 controls hematopoiesis. So ever since the 70s, people knew that JAK2 was important in hematopoiesis. And I've talked to Dr. Van Checker and others about this, and Gary Gilliland, and everyone was looking on the outside in the extracellular domain. And it wasn't until the early 2000s, and really 2004 or 5, that Van Checker discovered that this abnormality was in the intracellular domain of the protein. So that's kind of the history behind it. This mutation basically just keeps this JAK2 protein, which signals for hematopoiesis, and it's located on the outside of the cell. It keeps it active all the time. JAK2 drives hematopoiesis, but it's on when you're Lance Armstrong and you're taking EPO, or if you're on top of a mountain and you need to make more red blood cells, or if you're bleeding, you need to make more platelets. And it's off when you're not running up the stairs, when you're at sea level, when you're not bleeding. So your body regulates this, just like your heart beats faster when you run up the stairs and slows down when you lie down. The marrow is wonderfully adaptive, or it should be. In P. vera, this mutation is present in nearly all the patients, and if it's not, the JAK2 exon 12 mutation is there. These are less common in ET and MF, but they're still there. And I put this slide up just to kind of give you an idea that there's lots. Again, this is from a paper in 2010 from our friends at the Mayo. Ayulu Tafiri is probably the world's leading expert in myelofibrosis. And since that paper, this list has grown 50, 60 genes wide, like everything else in medicine these days. It's a lot more known about the molecular aberrations, not just mutations, but copy number changes in the diseases that we take care of. So JAK2 inhibitors, so the idea was if you've got this mutation in a gene that drives hematopoiesis, can you shut it off? Just like BCR-ABL. I told you BCR-ABL, the Philadelphia chromosome, is a mix of 9 and 22. Those two chromosomes come together, and that juxtaposition creates a constitutively active protein and signaling cascade in CML. I like to think of it, I'm not in Texas, but do you all have oil derricks in Iowa? I like to think of it like oil derricks, and they're supposed to be on and off. They're on when you need oil, and they're off when you don't. The BCR-ABL protein is on all the time, And there's a drug called imatinib, which was the first of the tyrosine kinase inhibitors, that just kind of gets in there and keeps the oil derrick from running. And that shuts the disease down. It's a beautiful thing. There's more papers about BCR-ABL and CML than there are patients with CML. It's been widely studied, and it's led to this kind of discovery. Unfortunately, it's a little different with myelofibrosis. If you shut off JAK2, you can't make more blood cells if you go to high altitude, right? You don't want to shut JAK2 off all the time. It'd be nice if you could shut off JAK2 617F, but as I'll show you, just shutting that off isn't really enough. Turns out it's less of a hierarchical dominant gene mutation-driven disease and more of a kind of a cluster of gene abnormalities that drive the disease. So JAK inhibitors aren't selective for the mutation or not. They inhibit JAK1, JAK2, JAK2 mutated, JAK2 wild type. That's what the WT means, wild type regular. The only way they preferentially inhibit JAK2 V617F cells is because that oil derrick's always running, so it's always in a position to uptake that drug, which makes sense. So I have in the bottom here that, you know, it looks like from mouse models we're never going to be able to get rid of the clone entirely for the reasons I just mentioned. But if you keep the patients, in this case the mice, on the drug, their spleens stay reduced for a while, and these are kind of mouse models of myelofibrosis. So this led to the clinical trials, and now one of these drugs has been discontinued. Ruxolitinib is now approved. SAR 302503 is about to be approved. And CYT 387 is going to phase 3. That's momelotinib, and I should keep your eye on that drug. That's a neat drug. LY 2784544 doesn't have a name yet, so I got to use that long alphanumeric name, but that's finished phase 2, and that's a neat drug, and I've treated about 10 or 12 patients on it with some success, and it targets specifically the mutation. Ironically, patients who don't have the mutation still can have benefit. I don't know why. So let's talk about the drug that's approved and you could get on the shelf. Ruxolitinib, or Jakafi, is a very potent but selective inhibitor of JAK1 and JAK2. Now, I told you JAK2 mediates hematopoiesis. JAK1 is involved there too, but JAK1 is primarily involved with immune mediation, and I like to think of it as an inflammatory heme signaling cascade, and that's important in a moment. Ruxolitinib also binds to the ATP binding pocket, so it slows down, and the ATP binding pocket is the same in wild type or mutated, so that explains why with this drug you can't preferentially target the JAK2 V617F, you target both. Serge Verstavstek at MD Anderson did a single institution study with 153 patients, which you can only do at MD Anderson. This is kind of the start, and I want to just give a background of how we got to the phase 3 studies, where 150 so patients, all from median age of 65, all with kind of a higher risk disease. You can see about 90% of the patients had intermediate to or high risk disease. There were a smattering of post-PET, post-PV, or post-MF. And all of them have been around for a while, treated for 6 years. So this is a sick group of patients. It's not going to be around much longer. It doesn't have a lot of options. If they went on this trial, they probably didn't have stem cell transplant as an option. And they had received multiple therapies. Other thing I'll point out is that, most of these patients were JAK2 positive, but some of them weren't. So pay attention to that, and I'll show you on a slide in a moment why that's important. So this graph is a little confusing. So let me just walk through because there's no green scale. It's all black and white. But essentially, regardless of dose that patients received on the trial, and they received one of two of the two doses, greater than 50% of patients had a 50% reduction in spleen size, or around a 50% reduction in spleen size. And the novel thing about this is the first time someone tried to get away with using spleen size as a real endpoint in a trial and then take that as an endpoint to the FDA. What's the FDA typically concerned with? Survival. So, this quality of life is a real paradigm shift, and a lot of convincing with the FDA, and it's changed things because there's a lot of drugs going through the approval process now that may not have a clear survival benefit as Rux does, and I'll show you that, but clearly impact how patients feel and how their quality of life is. So this hypothesis generating study showed a remarkable, quick, and sustained reduction in spleen size. And patients stayed on the drug for years. At this high dose now, up to 2 years. Now this is much longer. There's still patients on the study being followed. Typically, I don't know how many of you folks see myelofibrosis patients, but I'd like to just point out a few things in this slide. And I have many slides like this. I like this one because not only does it show the splenomegaly, but you can see here, without seeing the guy's face, you can see evidence of clear cachexia. You can see a xiphoid process in his anterior ribs in a way you shouldn't be seeing them. And he's got this kind of protuberant abdomen that you see in cirrhosis or myelofibrosis and a few other conditions. And he was treated for 2 months and he looked like this. So not only did his spleen shrink dramatically, but his secondary cachexia reversed. So that's a very satisfying thing as a physician to be able to treat somebody and have them and see them not only have an objective improvement like spleen response, but just feel better. I told you a moment ago that 82% of the patients were JAK2 mutants, and we thought at first that this drug would only work in JAK2 mutants. And as it turns out, it doesn't really matter. At least in these 6 patients, they were JAK2 negative. They still responded. And this is why this is a New England Journal paper. Not just because it made people feel better and they had smaller spleens and less symptoms, but because their inflammatome changed. I don't know how many of you are familiar with an inflammatome, and there's a problem with this slide. This is Serge's slide, but it's still valid. So I'll get to that in a second. So if you take patients who are mutation positive, mutation negative, all of these kind of inflammatory markers are grossly upregulated. And if you give them the drug, they go green. And these inflammatory markers are not upregulated. So it's a simple side-by-side comparison. Now, if you stare at this long enough, you'll see that all these aren't the same as these, which is the problem I have with this. I don't know how the editorial staff let them get away with that, but I guess it was the it was the claim and the correct claim that most of these are over on the right, and the ones that are not are also related to inflammation. I told you before that this drug inhibited JAK1 and JAK2, and we think that inhibition of JAK1 and that mediation of the hematopoietic-related inflammation is what's causing this. But I see this on a day-to-day basis, and I've probably treated 150 patients or seen people in consultation and send them back to people in the community who've then gone on to treat them and then call me and say, this, remarkable, not just spleen size reduction, but this guy's out playing golf now. So look like I'm doing okay on time, but I'm going to kind of go briefly through the clinical trials. And I won't spend a lot of time on this because I do want to allow some time for questions, but I want to give you an idea of how these studies were designed because there won't ever be studies like this again. Comfort 1 looked at ruxolitinib starting at a 15 or a 20 milligrams BID dosing based on what their starting platelets were, because it turns out the dose-limiting toxicity for the drug is thrombocytopenia. And it randomized people to one and the other, and then it crossed over the placebo failures. It only took patients who were intermediate 2 or high risk, just like the phase 1, phase 2, and you couldn't have platelets which were too low because we didn't want to have people bleeding on the study. The groups were evenly matched, and you should have copies of these slides, so I'll just go through this briefly. And the primary endpoint of spleen change in spleen volume is shown here at week 24. And pretty much nobody in the placebo arm had spleen reduction, and everybody in the ruxolitinib arm had some, 41.9%, greater than 35%. So that's a pretty big difference. And if you look here at the waterfall plot, individual patients had between an 80% reduction and a 5% reduction, with only 2 patients who had spleen increases while in the study, whereas people on the placebo arm, only 1 patient had a reduction in spleen size. This is the 0.7 here. That is 35% or more, and everyone else had either a small spleen reduction size due to variation, herbal diet, whatever, and everyone else's spleen increased. And if you look at changes in spleen volume and spleen length, both had rapid decline and then continued to decline over time. So this was very encouraging to us. Also, and probably more important as a clinician, is what happens to the total symptom score. And the total symptom score, if you're not familiar with this, is Ruben Mesa, and Ruben was a protege of Dr. Teferi's at Mayo, and then now he's at Mayo Scottsdale. And his research is based on quality of life and symptoms related to myeloproliferative neoplasms. And the total symptom score has been a validated tool in myelofibrosis for many years, and it was used in this study, and a greater than 50% reduction was what was considered meeting the secondary endpoint. And you can see here that almost half the Rux patients reached this endpoint, and very few placebo patients did. And again, the waterfall plot showing this by patient. And as I said before, the symptoms are variable, but the effect on the reduction of symptoms is variable. And this is a series of a variety of different symptoms that occur with myelofibrosis, broken out to see what happened to the total symptom score reduction for each of these things. And as there's such splenomegaly reduction, you would consider, gee, I think they have less abdominal pain, less splenomegaly. But it's interesting to see they also have dramatic reduction in itching. And don't tell anybody, but I've started giving people these drugs on trial and this drug on label for intractable itching. If they've got myelofibrosis and they've got little night sweats, their spleen isn't huge, but they don't respond to Atarax, Benadryl, Sinequan, I put them on this drug and their itching is gone. And these are people who come in with their skin caked under their fingernails because they've got so much itching. They can't work, they can't concentrate. It could be very profound. So I found that also fairly satisfying to be able to relieve them of that symptom. So the problems with the drug have to do with anemia and thrombocytopenia. And there's a grade 4 thrombocytopenia in a chronically ill, chronic malignancy is a big deal. For those of you who take care of acute leukemia, this is part of the deal. It's fine. But when you're taking care of myelofibrosis and you're used to seeing people like this on a monthly basis, grade 4 thrombocytopenia is not really an acceptable toxicity. And this is where we learn. The study looked at 15 and 20 milligrams BID, and I told you there's a dose-dependent toxicity of thrombocytopenia and anemia, right? Well, the label was for 15 and 20 milligrams PO-BID, and I can't tell you the number of patients who came to me absent a spleen after they had a ruptured spleen, which was emergently taken out after they were stopped on the ruxolitinib. So let me back that up and kind of walk you through what happened there. So the drug was approved in January 2012. People who read the New England Journal paper put the people on the drug. They had dramatic symptom reduction, but they put them on the labeled dose of 10 or 15 or 25 BID, depending on what their starting platelets were, right? And their platelets dropped through the floor. The first reaction as a physician is to get rid of the offending agent, right? So they stop the ruxolitinib. And what happens when you stop the Rux? Well, the shrinkage that you got from that JAK inhibition is you have immediate recoil, and the quick regrowth of the spleen leads to splenic infarcts and bleeding and splenic ruptures, and people would come into the ER with a hemoglobin of 4 because they're bleeding and have to have emergent splenectomies, which of course is, if there's any surgeons in the room, they could probably quote to me better mortality statistics than I could quote to them, but it's not a fun surgery and not a good thing for a patient who's already chronically ill. So this company and then other pharma, which are releasing these JAK inhibitors, are being smart and thinking about how do they rebound from that. because there's a lot of physicians out there who won't give this drug based on that experience. And again, as a function of time, I'm going to skip the BAT study. This is the European study. I'm going to spend a little time talking about the low platelet study, which I've participated in. And my mentor, Moshe Talpez, is the primary author. And this study said, well, do you have anything to lose by putting people who have low platelets on a low dose of this drug, because we know it's dose dependent, and then watching them and stepwise kind of increasing their dose over time to what we think is probably the most actionable dose. So if you had platelets between 50 and 100,000 and you had intermediate 1, 2, or high-risk disease, you were started on 5 milligrams twice a day. And we watch these patients like a hawk. After a month, sorry to use that reference in Ames. After a month, they could be increased if they didn't have a dive in their platelets. So this really needs to be updated. I'm sorry about an old slide here. But the moral of the story is that we were able to keep pretty much everybody on the study. And as you see the blue is the low dose. As time went on, people were able to tolerate higher doses. And there's some people who can even tolerate the recommended first labeled starting dose of 15 twice a day. Most people aren't there or probably won't get there. But it turns out that you can get benefit regardless, even at 10 milligrams twice a day. I'm going to show you why I think that's an effective dose. And this is kind of a take-home point for those of you who write this prescription. And now it's actually being changed on the label by the FDA. So the total symptom score and the spleen volume reduction, it's not as impressive as with Comfort, but you can still see these waterfall plots. Anybody who takes care of cancer patients, those are nice waterfall plots. And we like to see this kind of reduction in symptom score and spleen. It might be harder to get a drug approved based on this alone because it doesn't meet that kind of objective criteria, but we know how the patients are feeling and doing. And it turns out that their platelet count didn't really change much. You can see that the nadir platelet count is essentially not statistically different from their starting platelet count. Yeah, a few patients who are really on the bottom end who are kind of marrow deplete, but for the most part, patients hang in there with their platelets and you just find the right dose for them. Same with hemoglobin, where you have a drop in hemoglobin up to 2 grams per deciliter at the labeled dose. At the lower dose, we found that your anemia doesn't really drop so much. And this is what freaks out busy clinicians, right? If you're seeing 40 patients a day and you're expecting to see someone once a month, these are lab values that can really get the patient in trouble if you're not following really closely, and you just don't have a practice where you can do that. This is an academic center where all you see is myelofibrosis. So in that community setting, it's really important that these drugs are given in a way, or people understand the message, that these drugs can be given in a way where you don't reach those dose-limiting toxicities of anemia and thrombocytopenia. So as usual, I run over. I'll just talk briefly about finish like a cyclone. How about that? I think there's data now that ruxolitinib can prolong survival. There's a MD Anderson phase 1-2 study that looks at a historical control, but I think more importantly, you got to look at the Comfort data. And those curves are never going to separate as much as you'd like to see in a true study of overall survival, because those patients were switched over to ruxolitinib if they failed to receive response on placebo. So basically, everyone either progressed or they went back and went on drug, or they progressed and didn't go on drug. And I only have a couple minutes, so I just want to spend the last couple just talking about where we are now, and then I'll answer questions if that's okay. So Ruben presented this diagram, which has been reiterated many times because it kind of puts it all together where we are with treating this disease in early 2012. Low-risk patients, we were observing, we could give them interferon. Only JAK2 inhibitor for low-risk patients who have bad symptoms that are spleen-related. You may not get it paid for, and the payers are getting wiser to this. If you don't have intermediate 1, intermediate 2, or high-risk disease, you may not get the drug. And the drug's $90,000 a year, so it's not a trite thing. The patient assistance program is wonderful, but a lot of patients don't qualify for it. I think it's evolving, and I think now what we're looking at is always clinical trial, And there's a lot more clinical trial opportunities. I don't know if you have a clinical trial opportunity here, but if you do have an opportunity to get on the momelotinib versus ruxolitinib study, that's a good study. And that randomizes between a new JAK1/2 inhibitor that it has 50% of the patients have an improvement in anemia in the phase 2 setting versus Rux. Patients get the drug for free, and they get it's a winner study, so they get either one. So you may want to consider that study if you haven't been approached already by INC Research, who I think is the CRO, or Gilead, who's the sponsor. You know, thinking about allotransplanting these patients earlier in their disease, if they have the right symptoms, I think is also important. None of us who do allotransplants likes to take someone at transplant who we just know is not going to come out the other side, but we also don't like waiting too long. So if you have high-risk patients who are in good performance status, they should all go right away. But intermediate one, the timing is really tough, and following them closely is important. In the next couple of years, what we're going to see is the development of new drugs. And I didn't have time in this talk. In my hour-and-a-half version of this, I do. I'll spare you. But in the future, there is a variety of new drugs that are attacking the disease process, the natural history disease itself, by looking at reversing fibrosis. There's one drug called Loxel-2, monoclonal antibody to Loxel-2. Lysine oxidase 2 is seen in embryogenesis and then goes quiescent through adult life, and in pathology, in idiopathic pulmonary fibrosis, in cirrhosis, and in myelofibrosis. This gene goes bonkers, and you see very high levels of Loxel-2. And Loxel-2 is the chaperone protein for metalloproteases in the laying down of fibrosis. So they've made a monoclonal antibody to this, looking to see if it can actually reverse fibrosis that's already there. So that's kind of clever and interesting. There's another drug called PRM-151, which is looking at differentiating. It's basically it's a serum amyloid protein, which is not a pathologic amyloid, but an amyloid that causes the monocytes to differentiate, not to fibroblasts, but to differentiate into macrophages that destroy and break down fibrosis. So a lot of hope in the future there, and hopefully these things can be combined. And my work and desire is to keep people from allotransplant and to identify that small group of people who need to go to allotransplant quicker. But I think we can change the natural history of disease the way things are going in the lab. So I kind of ended quickly there in order to save a little time, and I really thank you for your patience, and hopefully you'll have some questions for me. I still think I have some voice left. Sir.
I'm a hematologist. I have a patient. Oh, excuse me. Thanks, Emily. I'm a hematologist. I have a patient doing well right now, but I know that won't last forever. I think about patients with other tumors where the dictum is, even though you have progression, don't stop. Think of GIST tumors and so on. What's the philosophy of patients who prog on a JAK2 inhibitor? Do they progress with splenomegaly, but their constitutional symptoms are still well controlled? Then what do you do?
Yeah, I mean, that's a great question. I think that the answer, as always, is it depends. So if the progression is fulminant, if people develop, an increased blast count and they need to be treated and go to leukemia, then it's obvious they need to be off the drug. And if you take someone off the drug, do yourself, especially if they had pre-existing splenomegaly, do yourself a favor and titrate down. Never take someone from 20 to 0. You'll get that rapid spleen, thing. Plus, they'll feel terrible and hate you, and they'll itch and everything else. But the patients who have, rapid spleen reduction and then slow growth of the spleen back, and I think you're talking more about those people, or they have night sweats, they go away, and now they start to have night sweats again. I kind of look at them and say, all right, well, how bad is it compared to where we started? And knowing now we're a year or 2 years later than when we started, so I'm expecting that if I did nothing, your disease would have done this. So if I take you off now and you go back up to here, if being on a drug, are you here? As you said, the dictum with GIST is to keep it like this and not this. It's really a judgment. It's really a judgment call. Like I said, I think the transformations to leukemia are a little more obvious, and the blast count, the generation of genetic evolution. There are some things. I had one slide to look at molecular aberrations. Icaros. If you see, I don't know if you do arrays or what the pathologists offer as sendouts and so forth, but University of Iowa actually has a tremendous molecular pathology lab. And if you're suspecting someone is a little higher risk for blast phase and they have Icaros abnormality, that gene is, that's an ALL, AML blast phase gene. And that's bad news. And if they pick that up, I think the writing's on the wall and you need to start planning on how you're going to change their therapy over. Sir, in the back.
Yeah, you talked about the cost of that drug, but I also had a question about what is the cost for the stem cell transplants? And then my next question is, if you have a patient who doesn't have insurance that covers either the drug or the transplant, what do you do? And is Obamacare going to change any of that?
Huh. Well, your guess is probably much better than mine on what Obamacare is going to do for any of us. I stopped watching TV. You know, the drug is about $90,000 a year retail. Nobody actually pays that. The insurers are all over the place. The copay ranges from $30 to $3,000. I have patients that pay both. Patients who have no insurance, as probably is your experience, are better off than those who have a little insurance. Patients who have nothing are better off than those patients who work but have a little. If they have no insurance and no income, then they all qualify for the patient assistance called Insight Cares, and the drug's basically gratis. The stem cell transplants, there are programs at university centers where people can have stem cell transplants done on the program. Those are fading away. I have a boutique center where we do 100 transplants a year, about 25, 30 allos. We can't do it. We don't have, a comprehensive cancer center grant to float us for that. So patients are referred elsewhere or sent to the NIH for a clinical trial where they can have a transplant. The cost of a transplant historically and it's a little bit of a, it's a standard deviation twice what the number is, right? It's about $500,000, but it depends on the contract that the institution has with the payers, which is based largely on volume and history and so forth. But once you do an allogeneic stem cell transplant, that's your patient forever. So it's an odds game. Sometimes allogeneic stem cell transplant can be done for far under the contract and the global pricing. And sometimes these patients develop chronic graft versus host disease and they're in and out of the hospital the rest of their lives for 3, 5, 10 years. So, then the costs are in the millions. And, we got to put our hands around this. And it's not my area of research, but I think the people who are doing the cost-benefit analysis and the quality of life type work are really doing a great service if they do it right. Because if you have a drug that costs $90,000 a year, but that $90,000 a year or $50,000 a year, whatever it is, can be justified by defraying a $500,000 cost, then maybe that's a good decision. But these these are becoming decisions that we have to, I hate to use the word ration, but we're getting closer to in this country that we've never had to deal with before, which is why, when you ask about Obamacare, I don't think any of us really know how things are going to go, and we just got our fingers crossed and we jumped in and plugged our nose and closed our eyes. Sir.
Just a simple question. Where do these NIB names come from? Where does the name come from?
Nib and Nab,
Yeah.
Nib and Mab. It has to do with the. I think originally it has to do with whether it was a chimeric, fully humanized, or how the drug was developed. So rituximab is a monoclonal antibody that's chimeric. So it's 95% human, 5% mouse. So that's a mAb. But I think that's historically, and now like ofatumumab is a mAb, but it's 100% human. So I think it's one of those things that's kind of a leftover. And if anyone knows more than that, please tell me and teach me, because that's what I know. I can't tell you much more than that. A lot of the NIBs are small molecules. The NABs are more monoclonal antibodies. Sir?
Excluding your future drugs here, can we assume that the present drugs and your inhibitors for JAK2 do not change the fibrosis in the marrow?
What a question. All right, so how much time do I got? So this year at ASCO, which is the American Society of Clinical Oncology, for those not in cancer in the room, I tried to do this study, but someone else beat me to it. But basically, they analyzed the marrow for patients on Comfort 2 from start, 2 years, 3 years, 4 years. And in some patients, there's reversal of fibrosis. It has nothing to do with their JAK2 status. It is often hard to correlate to symptomatic response, but there's a clear benefit, statistically significant benefit overall to some patients. We don't know what this means, and I say this with great caution because I'm certainly not saying that this drug has proven benefit to reverse fibrosis. What I am saying is that the longer-term data with JAK inhibition on the marrow seems to show that more than hydroxyurea, this drug actually changes the natural history of the disease. And I'll send Diarlis. I got a paper that's actually in review right now that is addressing this exact issue. You know, are we changing the natural history of disease of myelofibrosis with JAK inhibition and new therapy? And I can make sure you get a copy if you're interested in that topic. But that's a great question, and I don't think we know enough yet. No more questions? This has been a great group. Thank you so much for having me. Really enjoyed it.